congenital heart disease, different types of cardiomyopathies, and any other infections also can contribute. Normal infection like URTI, the virus, different types of virus also can contribute to the cardiomyopathy due to the myocarditis. So there's a lot of other rare type like your drug induced, such as patient that underwent chemo for the breast or the breast cancer or from the hematological cancers. And the newer types of chemo drugs also can contribute to it. And the rarer form is the infiltrative types, which is amyloid and sarcoid. Those who attended the medical CME 2 weeks ago, they discussed about the sarcoidosis, one of the patients. So there's so many causes, difficult to remember. So when you have the case of heart failure, usually nothing much from the clinical exam because most of the time patient already optimized before they come for your exam. So most of the time you won't have much sign or a sign that you can elicit from the patients. But if the patient was in the ward, still in the ward before discharge, or in the ward was still optimizing, sometimes you can see some of the sign that you can gather from the patients at physical examinations. So the most common one is your JVP. So this is a common assessment that you can see, especially those patients that have still in the ward. You can see the raised JVP, and don't forget about the hepatojugular reflex, which is most of you are always forgot to examine during the exam. From auscultation, if the patient still have symptoms, usually they have a bilateral low zone or bibasal collapse. If you look at the cardiac, if you assess the apex beat, if patient have a heart failure with a dilated heart, usually the apex beat is displaced already. And rarely you're going to get hepatomegaly or ascites. And a common one you can see is pedal edema. So which sign is more common? It depends on which stage the patient presented with. So if the patient presented with acutely, you will get more sign. If the patient is outpatient, you will get less sign. So it depends on which stages that the patient presented with, and depends on what time that you see the patient. So if you see the patient outpatient, you may not get all the sign. If you see the patient inpatient, you may get a lot of other signs. So it depends on which stage the patient presented. So when you see the patient with heart failure, you always look for all the signs that related to the heart failure. So there's a lot of signs that you can elicit or you can ask the patients. So the common sign and symptom that you can ask the patient is whether the most common one is your breathlessness. So whether is it cardio or is it respiratory cause, then you have to clarify with the patient regarding the associated symptoms. We will go through that one by one later on. So when you have suspicious of a cardiomyopathy, so you need to think of what is the underlying cause for the patient to present it with the specific symptoms. So if you look at the previous classification, you have different types of cardiomyopathy. You can hypertrophic, meaning the muscle is very thick. Dilated cardiomyopathy, meaning the muscle is either thin or thick, that causing dilated cardiomyopathy. Arrhythmogenic cardiomyopathy, it can be right heart or the left heart. Restrictive, meaning the heart is very stiff. And LV non-compaction, this is already removed from the classification of the cardiomyopathy recently. So first we start off with dilated cardiomyopathy. So meaning the LV chamber is dilated. Wait, I change to the... So the LV chamber is dilated. So there's different types of dilated cardiomyopathy. It can be ischemic cause, meaning it can be ischemic cause, meaning because of the ischemic cause of the thing. But idiopathic, there's a lot of things that you need to work out before you label the patient have idiopathic. But there are a lot of other secondary causes that can contribute to the dilated cardiomyopathy, such as chemotherapy, alcohol, hypertension, tachycardia, like what I should tell you, the AF or atrial tachycardia. Any form of tachycardia also can contribute to the dilated cardiomyopathy. So if you classify them, there will be different causes for each of it. There's too extensive and difficult for you to understand all this. So you must keep in your mind, there's a lot of cause that can contribute to the cardiomyopathy. So the common symptom of the cardiomyopathy that presented with dilated cardiomyopathy is depends on which one is predominant. So which cause that is contribute to the underlying problem. So you need times for you to gather the information before you label them as different cardiomyopathy. So in general, if the patient presented with heart failure is always a clinical diagnosis, okay, clinical syndrome. So you must have a sign and symptom of heart failure, and with at least one of the thing. Either you have an elevated NT-proBNP or BNP, or any objective assessment of the pulmonary or systemic congestions. So you can classify them into heart failure reduced EF, mildly reduced EF, or preserved EF. So these are the three classification that usually you see. And the last is your heart failure with improved EF, meaning the patient previously have EF less than 40%. And now when you repeat the assessment, the EF is more than 40. So this is classified under heart failure with improved EF. These are commonly seen in, for example, patient like myocarditis or peripartum cardiomyopathy. So when they have this heart failure initially less than 40, with the treatment or with the condition that reversible, then the EF improve. So these are the classification for you to decide on the treatment by the different cutoff of EF. So for heart failure, you must have sign and symptom plus at least one of these. So sign and symptom meaning the symptoms from what the patient tell you. The common one is the breathlessness, autopnea, PND, and pedal edema. These are the common one. And then the sign of heart failure like the elevated JVP, third heart sound, cardiomegaly, meaning you examine the patient apex beat is displaced and the hepatojugular reflex is present. And then you need at least one of it. So elevated NT-proBNP is commonly used compared to the BNP because this is more accurate compared to BNP. But if you have BNP only, also you can use that as a markers to tell you there's a heart failure. So the value you don't need to remember for your level, as long as it's raised, is considered heart failure. And if it's normal, then you can rule out to say that this is not heart failure. For master level, they need to remember the value. Okay, but there's always other cause of can give you the raised NT-proBNP. So patient presented with MI lah, pulmonary embolism lah, any other cause that can contribute to the stretch of the heart, it can cause the NT-proBNP to increase. One thing to remember is obese patient, they always have this so-called normal NT-proBNP. So if the patient obese but have sign and symptom of heart failure, you need to use other method to assess whether the patient has heart failure or not. So sometimes the NT-proBNP may be normal for this group of patient. So other objective assessment, like you can use the X-ray, the most simpler one, meaning you can, based on the X-ray, you have your back wings appearance or the upper lobe diversion of the vessels. And sometimes you can see that the heart is cardiomegaly. And this X-ray patient have a previous surgery done with a metallic valve. So this may be the clues that to tell you patient may have underlying problem that may predispose the patient to develop heart failure. Other parameters you can use is the echo, and also the invasive is the right heart catheterization. So easiest one is the echo because it's ultrasound and it's not invasive. So if you look at this, just now you look back the previous echo. So this is normal LV, normal function. So when you look at this, the heart is barely moving. So this is cardiomyopathy because of can be because of ischemic or non ischemic. So this is one of the clues to tell you, and this ejection fraction is less than 40%. And other assessment you can use is those who went for respiratory lectures before this. Nowadays they can use the ultrasound to assess the lung. So if you have these B lines, they can tell you that the patient have a pulmonary edema based on this. Normal you can see all the A line, but this is all the B line. B line is like your lighthouse line you will see from the lung ultrasound. If you can do the lung ultrasound, you sometimes you can see the pleural effusions. So when you have heart failure, what you're going to do with this group of patients once you have investigation? So the common one that you send is NT-proBNP, X-ray, and echo. So when you want to start them on treatment, so these are the four pillars that you start. So you can have ACE or ARNI. ARNI is your entresto, beta blocker, MRA, and SGLT2. So these are the four anti-failure that need to be initiated for the patient, either outpatient or inpatient, or you can start whichever combination that you want, as long as patient no contraindication, then you titrate them accordingly. So if you look at all the four, SCLT2 is the one that no need to titrate, only one dose and forever. So why is it important to start the four pillars? So ACE, ARB, and ARNI is classified under one pillar. So beta blocker is one pillar, MRA is one pillar, and SLT2 is one pillar. If you start all the four pillars, the number needed to treat is only four. So very much effective in treatment of a heart failure with reduced EF. So if you look at the guideline, so you start all the four pillars. The loop diuretic is not the pillars, it's just to improve the congestion, to decongest the patient. So the other four pillar is important. So these are the pillars that you need to be initiated for the patient. So when you have heart failure patient, you need to ask yourself why the patient is not on the four pillars. Any contraindication, anything that they cannot be started on due to any other reasons. So for example, some patient cannot start in beta blocker because of the severe bradycardia. So you can't start it. So you only can start the other three pillars. So this is an example. So some patients have very bad kidney disease. So your ARNI, MRA, and the SLT2 you can't initiate. So the patient can be only on beta blocker. So in the guideline, so after you start all the four pillars, then if the patient still have symptoms, then you have to look for other criteria. So whether they have any changes in the ECG, like they actually tell you like the LBBB pattern. So when they have a LBBB pattern, if the QRS duration is more than 150, they need to be on device therapy. If the patient have a ischemic cause, for example, patient have a SCS, or triple vessel disease contribute to the dilated cardiomyopathy. So this group of patients will need to be on ICD if their function EF is less than 35% with the MIHA class 2 to 4. This is green color, meaning is class 1 indication. And those patients is AF, so you need to be a anticoagulant and need to discuss about the whether you want to control them into rhythm control or the rate control. So it all depends on the patient's profile. If it's a short duration, not persistent, you still have a chance to improve. Even though those that persistent AF, you still can use ablation to improve the symptoms. So CRT meaning your cardiac resynchronized therapy, or either it's pacing or the defibrillators. It also depends on the criteria. So if you look at ICD and CRT, the criteria are almost similar. So must have at least 3 months of anti-failure, optimized anti-failure. So the difference between these two is the CRTD, you need the ECG criteria, meaning you need to have a QRS duration of more than 150, preferably LBBB pattern. This will benefit them to improve their heart failure symptoms. Okay, so the other things to look for is the iron. If you look at this part, so those patients have iron deficiency in heart failure, so they will respond well with the IV iron treatment. So the one that in the study is your ferric carboxy maltose. Okay, so these are the first line is your four pillars. These are all the second lines. After you have done all this, if you still have symptoms, these are the things to look for. So in exam, they rarely ask this lah. So usually ask you about the four pillars above. So you need to be familiarized with yourself. What are the four pillars that the patient needed to be on? Okay, and then rehab is important for the patient that having heart failure. So you need to rehab back them to improve in their symptoms. So if you look at the classification, we have EF of less than 40, 41 to 49 and more than 50. So these are different classification. Why is important? Because different classification have different treatment. So for less than 40, your treatment is 4 pillars. But for mildly reduced 41 to 49, your treatment is only proven one is only SGLT2. Okay, the rest is all class 2B classification. So meaning it's no strong evidence yet based on the trial. For 50%, EF more than 50%, you also see that the SLT2 is one of the things. So if you don't know what to start, SLT2 is you can start across whichever classification they are in. But 4 pillars only for this. This is only 1 pillars, and this is 1 pillar plus the 3. Okay. So for more than 50%, the second line is your A's, your ARNI and your ARB, and also your MRA. Beta blocker is not included in the more than 50%. So why? Because the evidence is more on the ARB for HEPF. Beta blocker, no evidence. So MRA and SLT2, these are the 3 that you can use for HEPF. For HEFREF, you have 4 pillars. So after you optimize the anti-failure, so you have to look for the evidence when you can use the ICD, because ICD is to prevent the mortality. It doesn't treat the symptoms. It only prevent the mortality. So if you look at the guideline, so after your first line, you look at the criteria, the ECG and also the echo criteria, whether they benefit SCD or benefit CRTD. So don't forget cardiac rehab is considered one of your 5th pillar. Okay, next is your Takotsubo cardiomyopathy. So I think this one also recently we discussed in the CME. Those that who are in medical posting, you have seen this. So Takotsubo meaning the LV function is actually impaired because of the mid to apical is hypokinesia. So the appearance of the LV is actually like the Japanese octopus trap. So it can present in anywhere. When you do angiogram, there's no blockage in the coronary arteries, but the patient EF is down, there's an apical ballooning. So it can present with any other ECG pattern. Can be TVF inversion, can be ST elevation. It can be any form of ECG that's suggestive of SES, but when you do the angiogram, it's normal. So there are various causes for Takotsubo cardiomyopathy. The one that you remember in your textbook is broken heart syndrome. Someone experienced some emotional stress for whatever reason, so they can cause the mid to apical LV that is become ballooning. Okay, so this is just for your understanding because it's too difficult for you. Okay, next is just now is the dilated cardiomyopathy. Now is thick heart, meaning the wall is very thick. Wall of the left ventricle is big, thick. So left ventricle hypertrophy, there are so many causes that can contribute to it. So these are a lot of causes that can cause the heart to be thickened, meaning your LV wall is thick compared to the previous dilated cardiomyopathy. So the common one that you can see is your hypertrophic cardiomyopathy, Friedreich ataxia, and also the Anderson Fabris disease. These are the commonly we seen. The rest are all very rare. Okay, Anderson Fabris and Friedreich ataxia, all these are not common as well compared to your hypertrophic cardiomyopathy. So when you have hypertrophic cardiomyopathy, you have different types. The one that commonly we seen is the sigmoidal and the reverse. Then your apical HCM, and also these are the whole muscle is actually uh, uh, thicker than the normal person. So if you look at the echo, sometimes if you look at different part of the echo, you're gonna get different thickness. So apical you only can see in the apex. So if you look at the other part of the LV is actually normal size. So if you miss this, you're going to miss the apical Hockham. So that's why correlation within ECG and the echo is very important. So you have different types of HCM. can be, if those that apical, they have different types of apical horcum as well. They can have aneurysm or no aneurysm. So this is too high level for you. You just remember the HCM, it's because of the thick wall uh of the LV. So when you have hypertrophic cardiomyopathy, ECG usually they have presentation is like looks like a LV strain pattern when you have a left ventricle hypertrophy. So you can use the voltage criteria or can use the appearance of the ECG. So you can see that there is a T wave inversion that is more on the lateral leads. Okay, and then you look at the QRS, the voltage is actually very tall voltage. So this is important because most of the time you label this patient as if let's say the patient presented with chest pain, you label this patient as a SAS. So when you do angiogram, sometimes it's normal. So it doesn't explain the ECG changes. So you have to look for the echo to see the thickness of the LV wall. So for those that apical, that is only apex that is thickened. So you can see that only the apex is thickened in the echo. The rest of the wall is normal. So it can give you the apical shape appearance. So that's why you can see the ECG can be widespread T wave inversion throughout most of the leads. So this apical HCM is also known as your Yamaguchi syndrome if you Google it. So it's similar lah. Okay, so HCM can present in anywhere. Can present with chest pain, heart failure, syncope, palpitation. It all depends on how they presented with, because everyone have different presentation. If the patient is young and presented with syncope, with the ECG and the echo suggestive, these are the things that you need to look for, and you need to ask about history, because usually HCM is autosomal dominant, so they're going to have a strong family history of heart disease. So the family history of a sudden cardiac death or similar symptoms you need to get from the patients. So when you have suspected hypertrophic cardiomyopathy, you need to get the history, especially family as well. Physical examination, most of the time you won't get anything from the patients unless patient have any other associated syndrome. And then you do need the ECG, echo, and also MRI to assess. And then of course, genetic is the best to identify different types of hypertrophy cardiomyopathy. So from the echo, you can look at any obstructions. Where are the level of obstruction that can cause to the patient presented with syncope. So this is too high level for you all. This is to show you that when you have a patient that have hypertrophic cardiomyopathy, you want to show that whether they have any obstruction or not. This is LVOT obstructions, meaning if you have obstruction, then you need to look for the what are the things that you can do to reduce the obstructions. So if they don't have, you can do the provocation test. So you can use the exercise test to see whether they have any dynamic obstructions, because some patients, they may not have obstruction at rest. So when they go for exercise, they fainted. So these are the clues to tell you that they may have obstruction that causing the patient symptoms. Okay, so if the patient have hypertrophic cardiomyopathy with heart failure, so you have to look for whether it is AF or not. If it's an AF, then you need to treat the patient with anticoagulant, regardless of the CHAPA score. So if you have hypertrophic cardiomyopathy with AF, patient need to be on anticoagulant. So for those that have this LVOT obstruction, so you need to look at the what are the things that you can do. So for medical therapy, we can give the medication to reduce the patient to develop the obstructions. But if all this fail, then you need the septal reduction therapy, meaning either you go in for surgery, you remove the septum, for example, this part, you remove it because this is the one that causing the obstruction flow to the aorta. Okay, so you can use this, or you can use the alcohol septal ablation, meaning you infuse the alcohol in this branch, so you make this area become infarct and become thinner. Okay, so for those that hypertrophic cardiomyopathy, you need the scoring for them, whether they need to be on ICD or not. So the scoring, you can use it. It's a calculator. You can put in the parameters, and then you tell you whether the patient need to be on ICD or can wait. So usually, if they have a family history of sudden cardiac death or patient presented with syncope, and then patient presented with arrhythmia, these are the clues that will tell you the patient usually will need the ICD. Okay. So if it doesn't have, then you need to monitor when they need to have when they require. So these are example of hypertrophic cardiomyopathy. So if you look at it, it's an autosomal dominant with variable penetrance, meaning let's say you have first generation you have HCM, second generation may not have, the third generation will have. So these are, it can skip the generation, doesn't mean each generation will have, because it's autosomal dominant with variable penetrance. Okay. Next group is your restrictive cardiomyopathy, meaning the muscle is very stiff. So the common one you see is your amyloid and also your sarcoidosis, and the rest are rare one. Okay. So the restrictive cardiomyopathy, they can present similar as your heart failure. They can present as arrhythmia as well. They can present with chest pain as well. So it depends on which stages that the patient presented with. So for amyloidosis, usually if you have, just now we say about LV wall thickness, right? So when your LV wall is more than 1.2 centimeter with any one of these, then you have to start thinking whether patient have amyloidosis. So the clue is sometimes patient have a carpal tunnel syndrome or the spinal stenosis. These are the common association. All patients have peripheral neuropathy and aortic stenosis, any other family history that similar presentations. So you have to start thinking whether this patient have amyloidosis. So why amyloidosis is always missed, because we only treat the patient with heart failure. We forgot about all these things. Understand? So LV wall thickness more than 1.2 cm with all these features, any combination of these. So you have to start thinking of amyloidosis. Why? Because if you miss the amyloidosis patient, or patient usually will die if you don't treat them within 6 months. Okay, so amyloidosis can be systemic and also cardiac amyloidosis. Systemic meaning is hematology patients. Usually is a light change. So that's why it's important to send the serum free light chain and also serum and urine electrophoresis. So if they are negative and you are still thinking the patient have this amyloidosis, so you can do this pyrophosphate scan. This is a nuclear scan. So to help you to classify them into whether they have amyloidosis or not. So this is the only condition that you don't need biopsy. Remember? So this you need the nuclear scan to tell you if they have grade 2 and grade 3. So you are more likely to have cardiac amyloidosis without require any biopsy. Okay. So the nuclear scan is important, because when your nuclear scan is positive with the hematological test, meaning your serum and urine electrophoresis and free light chain is negative. So when the scan is positive, you already can safely tell the patient that you have cardiac amyloidosis compared to the others conditions. So amyloidosis, like what I say, you can present with any combination of this. So most of the time we will miss the cardiac amyloidosis. Why? Sometimes these patients are presented to orthopedic. Okay, sometimes this group of patients are presented to orthopedic or neurology patients. So you will miss this, and then you never think of whether is it amyloidosis or not, if they don't have heart problem. Okay, some patients have this previously, then now presented with heart, then you have to think whether is it correlate. Okay, so always have a suspicious when you have patient that have a combination of different uh symptoms, and then that you cannot explain the degree of the heart failure, then you have to think of cardiac amyloidosis. So the common question they ask is, when you have amyloidosis, if you look at the echo, remember just now the LV wall thickness is more than 1.2 centimeter, right? So when you have a hypertrophy in the echo, but then your ECG is actually no hypertrophy changes, no LVH trend pattern. So this is called discordant. meaning your echo and also your ECG not tally. So these are called discordant. When you have discordant, you should raise suspicious of amyloidosis. Okay, so we in Asian we have our own diagnostic algorithm similar as the guideline. The international guideline is the same one. So important is to rule out AL first because AL is belongs to hematology. Okay, AL amyloidosis is belongs to hematology things because I need to start chemotherapy for them. For cardiac ATTR, you need different types of treatment. So the one that available in Malaysia now is tafamidis. Okay, tafamidis is actually to stabilize the protein so that it doesn't to prevent the disease progression. So amyloidosis have different complication. So need to be work out for those patients that have any symptoms, then you have to treat according to which complication that they're presented with. Either it's a heart failure, AF, or arrhythmia. So if they have arrhythmia, they need to be on ICD. AF, you need to be on treatment or ablation. Heart failure need to treat them with the anti-failure that I mentioned previously. Okay, so for Anderson Fabry disease, this is rare, not common in Malaysia. So this is just to tell you, you got no need to remember because this is just for your knowledge only. Next is your cardiac sarcoidosis. So I think this one we discussed about 2 weeks ago in the medical CME. So these are the things that also rare, but we always miss this group of patient. Why? Because uh sarcoidosis can mimic anything. It can be from head to toe. Any part of the body also can have this sarcoidosis, and it's a great mimicker. Can present with any symptoms. If the patient have sarcoidosis involving the brain, they will be end out in neuromedical clinic. If the patient have sarcoidosis involving the lung, you're in the respiratory clinic. If the sarcoidosis involving the skin, they'll be under the dermato clinic. So it all depends on which presentation they presented with. But for cardiac sarcoidosis that involving the heart, usually they're presented with uh, heart block. Okay, high degree heart block. They may or may not have heart failure. The one that we discussed 2 weeks ago, the patient only have heart block, doesn't have heart failure, and there's no arrhythmia. And the patient have the lymph nodes in the lung that biopsy proven to be chronic granulomatous lesions. So when with these two combination, you're gonna get suspicious of cardiac sarcoidosis. So the patient went for PET scan, which confirmed there's a uptake in the 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 heart, which suggestive of cardiac sarcoidosis. So the treatment is gives the immunosuppressant, your steroid. Okay, corticosteroid or the combination with non-steroid based treatment. Okay, so sarcoidosis is rare, difficult to get because we always miss because patient presented to different clinic, so you don't have much of information. So the criteria for that is you need biopsy result. So you need to have biopsy proven, not from the heart, actually from other part of the body. Let's say from the lung, from other place, and then patient have any sign any cardiac involvement like your heart block or that or arrhythmia or heart failure, then you plus the imaging, then you're going to get to the diagnosis of your cardiac sarcoidosis. Next is your ARVC. I think Dr. Aship mentioned about ARVC is not only purely for right heart, right ventricle, it can be left ventricle as well. Commonly patient presented with arrhythmia, especially the VTBF. So they need to be on the ICD for this group of patients. So for cardiomyopathy, these are the approach to assess when you have a patient presented with heart failure. So you need to think of whether they are which group they are in, whether they are less than 40, more than 50, or whether it's a normal wall thickness or is it increased wall thickness. And then the common things that we need is your echo, MRI. These are the two important things that you need to have to give you some clues to what are the cause. And then for those that have infective cause, you need to send the infectives whether it's a viral or any other underlying things that you suspect, then you can send the assessment based on the clinical suspicious. So it's very difficult to tell you what to send. It all depends on what you get from the patient from based on the history. Okay, so these are the example of the MRI that you can use to differentiate different types of cardiomyopathy. And this is not your level, okay? This is postgrad level. Okay, it won't come out in your exam. Okay, so how to approach to patient presented with breathlessness. So when you in your long case, usually your long case is either your respi or your cardio. So when you get the case, patient tell you the chief complaint is breathlessness. So in your mind, you have to think of which are the system that you deal with, whether it's cardio or is it lung. So you have to get the further history, what are the relevant information that you need from the patient. So for heart failure, so you get the history of all the heart failure, but don't forget about your lung. So when you suspect, when the patient have a lung cause in your heart, in your chief complaint and associated symptoms, so the next thing of your screening also you need to exclude the lung, exclude the heart as well. So don't forget when you get, so a lot of you when in the exam you're too focused. So when the patient tell you I got shortness of breath, chest discomfort, wheezing, so you think, oh, okay, this is asthma and this is COPD. So you focus, finish already, then you forgot about to relevant negative history. You need to rule out the cardiac cause. Okay, or you get the case and you think that this is you got a history that's suggestive of heart failure. Then you work out, you focus everything about heart failure. Then you forgot about the lung cause. So you just need to ask some screening question to help you to exclude the respiratory cause. So the easiest way is you just ask screening question. So for example, let's say you don't think it's a heart failure. So you ask the autopnea, PND, everything you ask already. So patient said don't have, you just need to remember you put in your history to exclude as at the after you finish your respiratory plugging. Understand? So don't forget to exclude all the things, because in the end, when you want to say your differential diagnosis, these are your things that to justify your answer. So when you have dyspnea, you can divide it whether is it cardiac cause, pulmonary cause, or any other cause that can contribute to the same symptoms. So for the cardiac, it can be because of the heart failure, because of the ischemic heart disease, valvular heart disease, pericardial disease, or arrhythmia. For the pulmonary, it can be because of the obstructive lung, which is your COPD and also your asthma. And restrictive lung disease, meaning patient have any underlying anatomy that can contribute to it. For example, your scoliosis that contribute to that. Whether any pleural problem or chronic pulmonary embolism that can contribute to the symptoms. Anemia is like those that chronic anemia, high output failure also can give you your dyspnea. Neuromuscular, like those patients have all these neuromuscular disease that can contribute to the dyspnea. Deconditioning, for example, those patients have a prolonged hospitalization, prolonged bed bound. These are deconditioning can contribute to the breathlessness as well. The last is your psychology lah, anxiety patient. For patient presented with edema, it can be due to any other cause. So if you have a case of edema, so you think whether is it a heart or is it a kidney or is it a liver, because these three organ is the one that contribute to your contribute to the edema. So you in your history you need to get more history which organ that this patient is belongs to. Okay. So I give you an example. So you have two person with dyspnea on exertion. So let's say this patient individual A. So you have a patient with a CKD, AF, and hypertension, BMI of 31. And then this patient have a same thing but with a carpal tunnel syndrome and lumbar stenosis. So what is this? This patient, individual B. Anyone?
Amyloidosis.
Yeah, so this is clues, this is clue. So to tell you this patient have amyloidosis that you need to work out. So whether it's AL or cardiac amyloidosis, you need the further testing. So even though it presented the same, but because of any other things that extra you need to keep your mind, because the scoring system for this patient is different. This patient may have score 9, this patient is score 6. So the higher the score is more of heart failure with reserved EF. So doesn't mean both the patient also have more than 5 already. So both are under category of heart failure, but which are the underlying cause for the heart failure. So these are the things that you need to work out. So that's why history is very important. Don't just focus on uh heart failure only, because heart failure nothing else for you to ask. You only can breathlessness, exertional dyspnea, then your autonomic PND. Then what else in your history? Your long case don't just stop there. You need to exclude the other cause. Okay, it all depends on what you get and what are the further investigation needed for the patients and which system that you suspect, and then you work out based on that. I don't need to go through all this. You can read from the algorithm. So things that I want to emphasize is edema doesn't mean that it's equivalence to heart failure preserved EF. So even though your echo tell you that it's normal, so you need to look for other cause. Like what I say, the three organ is your heart, liver, and also your kidney can contribute to your edema. So your job is to find out what is the cause. So it can be either heart or lung or any other cause that contribute to it. So you need to get more history for this. And the most common underlying cause is all this that we always forgot to ask. Okay, so always get the patient history. You need to ask specific for all these things. So amyloidosis, like what I mentioned just now, you can have your carpal tunnel syndrome, spinal stenosis, or any heart block, heart failures. Hypertrophic cardiomyopathy, important is your family history, and then usually occurs in young patients. Sarcoidosis, they have any other organ involvement most of the time. Either it's lung, skin, or brain, neuro lah. So they can have any other involvement as well. Hematochromatosis, these are rare, but then these are we always forgot. Fabry is also rare. High output failure are those that anemia, for example. Myocarditis, you need to think of what is the possible cause of myocarditis. For example, the previous pandemic, your COVID-19, it can contribute to your myocarditis. Any viral infection, like your any URTI, your influenza lah, all the different types of virus can contribute to your myocarditis. And pericardial disease, in Malaysia, commonly is your TB. So all this, when you have heart failure that you cannot explain, all this need to be further investigated with different types of imaging. MRI and your nuclear scan will help you to identify. So patient with dyspnea and also edema, so you have to look for other non-cardiac cause before you label them as only purely because of the heart. Okay? Anything you want to ask about this before we go to here? Okay, anyone want to answer? Okay, anyone? Yeah, I call the name. Mana orang? Start from below lah. The last person on the list. Zhang Jiat. So what's the answer?
Is it hello, am I audible?
Hello. Can you hear that?
Hello, yes. Is it donkey?
Why?
Because of the heart failure and
So this patient have dilated cardiomyopathy, right? So EF is 30%. So he's categorized under heart failure reduced EF, less than 40%. Okay, he's under category. So when you have less than 40%, so you need the four pillars, remember? So patient already
yes.
have worsening of heart failure, so require IV Lasix, already decongest in the ward. So now he's already on NRapio, which is your ACE, spironolactone, which is your MRA. Your bisoprolol is a beta blocker, and then your BP heart rate also quite okay. So what are the things next to start is your SGLT2. SGLT2. Okay,
Got it.
understand. So your digoxin is only useful for those that with heart failure with AF. So those patients have AF and heart failure. So digoxin will be the class 2 indication. So your second line of treatment. So CCB not useful in not useful in heart failure at all. So it can worsening your heart failure. So don't use the CCB. This is your funny channel blockers, which is your ivermectin. So this is useful if you cannot optimize the beta blocker, and the patient heart rate is still more than 70. So you can use ivermectin. Ivermectin is second line. So your first line is still your SGLT2. Okay. Now the question is not moving. Okay. Number two. Anyone want to answer?
D.
B or donkey?
Donkey. Donkey, doctor.
Why?
Because as you explained just now, doctor, this patient had sudden chest pain and syncope on exertion, and then his ECG shows a left ventricular strain pattern, which could mean that there is hypertrophy, and also that two of his other siblings passed away at a young age. So all of these point to hypertrophic obstructive cardiomyopathy.
So it can be HCM or HOCM. It can be with obstruction or without obstructions. So these are the things. So clue is usually you look at the stem. Usually they'll have family history one. Okay, usually you have family history. Okay. SCS is possible because patient have a chest pain, right? But then, which is most likely because the enzyme is normal and then have strong family history. So this one rule out, rule out. Young patient rare to get PE unless you have any APRS syndrome. Aortic dissection if your blood pressure is very high presentation. Okay, so the most likely diagnosis is your HCM. Okay, next. Okay, why not jalan? Okay, next. Okay, anyone want to answer? Describe the chest X-ray. 2 marks.
There's cardiomegaly.
Okay, cardiomegaly. What else? So some of you were right. The cardiothoracic ratio increase strategy for cardiomegaly can up to you. If you got time in exam. Okay, what other things?
Planting of the left costophrenic angle.
The what left costal planning angle meaning the
Planting of the left costophrenic angle.
okay lah, some little bit of fluid there. Okay, fine. What else? The more prominent one, your upper lobe diversion, right? So you can see all your upper lobe diversions. This one don't have back wings yet. This is a clue to tell you the patient have heart failure sign because you have cardiomegaly, the heart is very big, and then you have all these prominent vasculature, upper lobe diversions. So what is the most likely diagnosis based on the information given?
Decompensated heart failure.
Okay, you can write congestive heart failure, decompensated, acute decompensated heart failure also can. So why? Because patient have a sign and symptom of heart failure plus your radiology radiology sign of heart failure. Okay, so two important investigation which may help to confirm your diagnosis. What investigation you want to stand? Which I mentioned in the slide before this.
BNP.
Okay, best is your anti-pro-BNP lah. Okay, if you don't have anti-pro-BNP, you can send the BNP. Okay. In exam you have to write natriuretic peptide. Then you bracket there anti-pro-BNP. Okay. The other one.
Echocardiogram.
Yeah, echocardiography. Why is important? Because you want to classify them into whether it's EF less than 40, 41 to 49 or more than 50. Okay. So echocardiogram is to assess the heart functions, and then your antiprotonemic, if it's raised, then it's most likely is a heart failure. Okay, what if the antiprotonemic is normal? And what other things that can explain the X-ray? If I give you the ECG. So you have to think of what are the cause can cause cardiomegaly. So sometimes some patients have global pericardial effusion. Okay, because you cannot see from the X-ray, for the global pericardial effusion, it looks like cardiomegaly from the X-ray, and the sign and symptom almost similar. So the only thing, the clue is, I give you another ECG, which is, what is the things? The ECG may be small complexes or the electrical alternance. So if you have electrical alternance, then you have to think of whether the patient have a cardiac tamponade. Okay, so the question may be twist based on what the scenario was given with the same chest X-ray. Okay, so two common causes for the diagnosis. What's the possible cause? Your dilated cardiomyopathy lah. That's how we saw, right? That's how we talk about it. Dilated cardiomyopathy. So what's the cause for dilated cardiomyopathy? Myocarditis lah, ischemic cause lah, SCS lah. You can write because there's so many causes. I just remember the table. There's so many. Up to you what you want to write. But it depends. Exam you have to depends on what are the things that given. So sometimes they give you some clues there. Patient have a previous URTI 1-2 weeks ago, or something like that. So that is the viral cause of a myocarditis can contribute to this. And then idiopathic dilated cardiomyopathy. These are the example. So what are the medication to treat this condition?
The 4 pillars.
Yeah, which one?
Uh,
How are you going to write your exam? Yeah, in the answer. So you write the 4 pillars. So the first pillar is your beta blocker. Then you can write next is your ACE or ARB or your ANI. Okay. And then you cannot write short form, you can write full one. And then your third pillar is your MRA, such as your spironolactone. And then the fourth one is your SGLT2, which is your empagliflozin or your dapagliflozin. So these are the 4 pillars that you require to start for this patient. And then the patient's BP and the heart rate also quite good for you to start the medications. Okay, next.
the question. Do we start the medication one by one or we throw start all 4?
Like what I mentioned to you, you can start any combination you want. It depends on patient's clinical status. If the blood pressure is borderline, you cannot start all together. So if the patient blood pressure is high, like this, for example, so you can start low dose all the medications. And if the patient is still in the ward, you are still decongesting, so you cannot start all together. So you have to start one by one. So depends on the patient's condition during that time. So generally, if you follow the old guideline asks you to start beta blocker first, then followed by ask you to start ACE first, then followed by your beta blocker, followed by your MRA, followed by your, if you cannot optimize, then you change the ACE to your ANI. And then if you still cannot optimize, you add on the SLT2. This is both based on the old guideline. Okay, why like this? Because all the drug was study one by one like this on top of each other. So but nowadays we don't use this anymore because it's time consuming and you cannot optimize fast. So it depends on the patient condition. You start whichever that is suitable for the patient. So for example, you can start your ACE and the beta blocker for the patients, and then you add on the spironolactone after that, and then you can add on the SGLT2. Or if you worry with, let's say the blood pressure is low, borderline, you can start your SGLT2 first, because SGLT2 won't cause much of the blood pressure effect on the blood pressure. So you can start SGLT2 first, and then you add on others medication as patient can tolerate. So there's no right or wrong how you're going to start. Is the patient condition. It depends on the patient condition for you to decide how to start. So as long as you remember, 4 pillars are needed for the patients. Whichever combination you want to start is up to you. And then as long as you slowly titrate up each of the medications. The only medication no need titration is your SGLT2 because only one dose and it's forever. Okay, next. Okay, ECG, anyone? Okay, anyone want to answer? Okay, this how we start from below kan. Alamak, so now we start from the top. Siapa? Alamak, no name one. Fatin lah, Fatin Khairiyah.
It is a sinus ECG, sinus rhythm.
So what is the finding in the ECG?
Hello,
Can you hear that?
can you hear me?
A bit soft.
So it is sinus rhythm
Okay, sinus rhythm.
with rate of
So you got, let's say you got 4 big blocks, so it's about 75 beats per minute. So 300 divided by 4, so you got 75. Okay, what else?
with ventricular hypertrophy.
So you have left ventricular hypertrophy strain pattern. Okay, what else? What is more prominent here? So you have all your, you see your T wave inversion, most of the leads. Okay, and these are not the typical type of left ventricular hypertrophy strain pattern. Okay, usually the strain pattern, the T wave inversion won't be so deep one, and so you see this T wave is very deep, and this is a LVH strain pattern. So what are the, based on this thing, what are the information? Based on the information, what is the likely diagnosis? Already give you the clue, right? So patient have.
Perfect cardiomyopathy.
So patient have a hypertrophy cardiomyopathy. It can be have obstructive or non-obstructive cause. Okay, but this patient presented with syncope, so probably he have obstructive cause lah. Okay, so the answer will be your hypertrophic cardiomyopathy with or without obstruction lah. So three important investigation. How you gonna do? What investigation you wanna do?
Echocardiogram.
Okay, echocardiogram. We want to look for left
Obstruction.
ventricular hypertrophy and also any which level there is obstructions. Okay, what else?
Stress test.
Stress test can, but then patient already pensan already mah kan, already syncope. What you need to do stress test? No need already mah. So you already have the symptoms already. So you just need to have, and next step is you already have ECG, right? So next is your echo. We have echo, what else? Your MRI.
MRI.
Okay, MRI. Why? Because you want to look for where is the problem. Because the MRI can tell you which part of the muscle is fibrosis. Okay, and the third test is your genetic, because you want to know they are in which group of which type of genetic problem for the patients, because HCM have different gene. So you want to find out which one, because some of the gene are very prominent. So meaning the next generation, they'll, because he already have his brother passed away already at young age. So if the brother he has, so he need to think of his next generation, his children. So he need to screen for the children already. Okay. So two common complication. So what common complication? What the hypertrophic cardiomyopathy can cause? Sudden cardiac death, right? Already got answer ma. Brother already passed away. So sudden cardiac death. One more. Remember the calculator? I tell you got one thing there. Patient got arrhythmia lah. Usually your VTVF. Okay. So sudden cardiac death and your ventricular arrhythmia. Okay. One important primary prevention for this patient. So what you're going to do to prevent patient from sudden cardiac death? To prevent like what his brother is happening to his brother. So what is the things you need to do for this patient? Remember the calculator I told you? The patient need to be based on the risk score. You need to calculate the calculator. If the patient have high risk, they need to be on ICD. Okay? Remember? Understand? Anything want to ask? Got
Betul, just pacemaker.
okay, pacemaker is for heart block. If you have AV block, okay. If you have ventricular arrhythmia, you need ICD. Where is it? Where is it? Where is it? Okay, right here. Ada more. Too fast already. Okay, so when you have your non-sustained VT, when you have VT lah, arrhythmia and family history of sudden cardiac death, so these two are important. When you have this, if you put in the calculator, they are automatically the patient will be in high risk, so they will require ICD. This is primary prevention. Okay, unless the patient have VTVF already, patient presented with VTVF that causing the patient to have syncope, or patient have uh, event that already occurs, then you need to be on secondary prevention, meaning patient already have the event. Okay, primary patient doesn't have yet. This patient is presented with syncope only mah kan. So, and then if you do all the investigations still don't have, then you don't need lah. If the patient have non-sustained VT and family history of sudden cardiac death, if you put in the calculator, most of the time they are in the high risk group, so they need to be on ICD. Okay, so these are the things that need to know when you see the case of hypertrophic cardiomyopathy. So in UKM, we have a few patients that is undiagnosed hypertrophic cardiomyopathy that follow under different clinic. And then after some many months, many years of follow-up, only noticed to have this hypertrophic cardiomyopathy. So it's always if you saw the ECG that is LVH trend pattern, always have to look for the echo, and then look for the features that can explain the ECG changes. Sometimes the hypertrophy is at the apical of the LV. So if you don't look carefully in your echo, you will miss the apical. So patient may just have sudden cardiac death and then just pass away like that. So always don't miss the thing. So always must be tally. So like Dr. Ashi tell you, right, when you have ECG, if you look the ECG is normal and the patient echo also normal, so it's less likely to have hypertrophic cardiomyopathy. So if you have patient ECG abnormal, but your echo also abnormal, if you ECG abnormal but you cannot find anything in echo, then you think what are the things that you miss, whether your echo is wrong or the ECG is wrong. Okay, so these are the things that are important to look for. Okay, anything you want to ask? Anything you want to ask? Any question? Oh, 1:30 already. Anything else? This is my last slide, I think. Yeah.
There is a question.
Hmm.
Student.
If a person presented with acute heart failure, it should be treated based on their condition and proficiency. Yes, that's why I give you the chart, right? So the patient have a warm and wet, warm and cold, warm and dry, warm and dry, warm and wet, and cold and wet, cold and dry. So it depends on the patient presentations. So in the I go back to the do I go back there? Okay. So if patient presented with this one. So it depends on which timing that you're seeing the patients. So it will be depends on condition. Then you treat based on the patient condition. So for example, patient is wet, so you need to give the diuresis. If the patient is cold, meaning the perfusion is not good, so you need to start some inotrope to support. So it all depends on the how the patient presented with. And then once you optimize, and then you slowly start your anti-failure after that, one by one. So you can start whichever one that can support. Because for those that cold and wet and cold and dry, usually the blood pressure is very low, and And for those that is warm and wet, usually the blood pressure is still okay because the perfusion is good. So you can add on the anti-failure faster. Okay. Any question? Okay. Any more? Any more? Any more? For your level, you just need to remember the pharmacological treatment. The four pillars for heart failures. The four pillars only apply for reduced EF less than 40%. So for more than 50%, the one that class 1 indication is your SGLT2. And your more than 50%, beta blocker no benefit in this group of patients. You can use the beta blocker for HFpEF, provided they have other indication. For example, ischemic heart disease lah, AF lah. So these are the things that you can use the beta blocker, but it's not for the heart failure. Okay, so SGLT2 is class 1, and then class 2 is your ARB, not ACE or ANI. And then you can use the ARB, that you can switch to ANI, then your MRA. So these are out of the four pillars, they only can use three for HFpEF. For mildly reduced, you can use still four, but then the class 1 is your SLT2. The rest are under categorized class 2 indication. That's why your exam question mainly focus on your heart failure reduced EF, because the mildly reduced and preserved EF, not much of question can ask because not many medication can be used. And then that is for pharmacological treatment. For non-pharmacological treatment, it's like your fluid restriction, low salt diet. These are important. Okay. Anything else?
Sorry, doctor. Just wanted to reconfirm for a patient that have kidney disease with heart failure, what anti-failures that they should avoid?
Okay, so for CKD patient with heart failure, so you have limitation in the anti-failure. So for example, your EGFR less than 20. When your EGFR less than 20, you got not much of choice available already. If this is a newly diagnosed heart failure. Okay, so for beta blocker, you can use in whichever stage of CKD that you have. So whether they are dialysis, CKD stage 5 or already started dialysis, beta blocker you can use. For ACE and ARB, depends on the patient's condition. Okay, if the patient already on ACE and ARB before this, they can continue until their dialysis, provided the no problem with the potassium. Okay, for MRA, spironolactone, you can use as long as the EGFR more than 30 more than 30. If the EGFR more than less than 30, you got not much of evidence already, because the study only up to the cutoff is up to 30. Less than 30, if you want to use, you have to use with precaution because it can cause hyperkalemia. For SGLT2, is less than, when you have less than 20, there's not much of evidence because the study only up to 20 only. So more than 20, you still can use the SGLT2, but less than 20, you cannot use already. So for Entresto, is the ANI is similar, which if your EGFR is more than 30, you still can use. Less than 30, not much of evidence, but in the study, they can use up to EGFR 15. But the lower the EGFR, the things that you need to consider is the hyperkalemia, because your ACE, ARB, MRA, and also your ANI, all these can cause the hyperkalemia. So need to be careful when you have EGFR lower and lower and lower. So for all the patients with CKD and heart failure, beta blocker you can use, but the rest of the medication you have to depends on the EGFR level if they are newly diagnosed. Okay.
Thank you, doctor.
That's why heart failure and the CKD patient very kesian, not much of choice of medication. So you only can give beta blocker and diuretics only. the study for the SGLT2 and also ANI, the Entresto in the CKD stage 5, still ongoing. I think should be out in 1 or 2 years time. So hopefully we get some answer from that. In reality, sometimes we still use the ANI in CKD stage 5 if they don't have problem with the potassium, because if they can improve the heart failure, then we can use that. But all these are off-label use because the study haven't finished. The trial haven't finished, still ongoing. The MRA use, spironolactone use in the CKD stage 5 already finished study, but I think the result not published yet. It's supposed to be published this year. But they doesn't fulfill the clinical significant statistic criteria, so that's why no news until now. Okay, anything else? Anyone know about this bentopnia? I put a picture at the side here. So this become famous recently due to the COVID pandemic. So this is a simpler way to assess the patient whether have a symptom or not. So when the patient bend forward, they have breathlessness. These are the sign of heart failure actually. So during the COVID time, you want to assess whether patient have a desaturation of oxygen, whether they have symptom or not, because this is one of the tests they can use.
If there is no more question, and end this session. Any more
Okay.
questions from the participants?
Okay, if you have any other things, you can WhatsApp me or anything you can ask. All right. Where's my current group? I cannot see where's my current group. Got Tan Ziying punya group. Okay.
If there is no questions from the participants, can end this session. Thank you, Dr. Bay, for the informative session and for spending your weekend with us, all the students. So, ladies and gentlemen, that marks the end of our webinar. I would like to extend our heartfelt appreciation and gratitude to all our esteemed speakers for generously sharing their extensive knowledge, providing us with valuable insights on the topic we have explored today. Your expertise has truly enriched this session and left a lasting impact on us. I would also like to express our gratitude to all the participants for your active engagement and enthusiastic participation throughout the session. Your insightful questions have greatly contributed to the success of this webinar. So before we call it a day, I would like to ask the participants to spend 1 minute filling up the feedback form for today's revision webinar, which will help us to improve the webinar in the future. You may find the link in the chat box to fill up the feedback form. Once again, thank you for joining us today. We hope that you found today's webinar informative and beneficial. We eagerly anticipate your presence in the next webinar scheduled 2nd of June 2024 from 10 a.m. to 1 p.m., where we will be discussing more on the nephrology system, specifically on 3 topics, that is approach to nephrotic and nephritic syndrome,